So, good afternoon, everyone, and good afternoon, Professor Board. Thank you for joining us.
Welcome.
Yeah. And so today we will be talking about the risks and complications in hip replacement surgery. I guess it's unlikely to be anyone's favorite subject, but it's an important subject for anyone having this operation to get an understanding of, both as a part of informed consent and setting expectations, but also I think in terms of being able to take an active role in one's own treatment plan. And I think sort of that feeling of knowledge is power and being able to be informed and empowered to, to be comfortable and confident in the treatment plan and sort of take a bit of a shared role around that.
Yeah, absolutely. I mean, I think it's vitally important that patients understand that any operation is a risk benefit balance,
Yeah.
and they need to be part of that decision making, process. Patients need to sort of request surgery. Really, I almost never tell a patient you've got to have this operation.
Yeah.
It's more, in orthopedics and in joint replacement, it's a quality of life operation, not a quantity of life. You're not saving someone's life. You're trying to improve the quality of it. So they need to decide, is my problem severe enough to warrant me going through this when there are these risks?
Yeah.
So they can't, make an informed judgment unless they know what those risks are.
Yeah.
The kind of conversation that we're going to have in this, this recording is very much going to be just like what we talk about in the clinic.
Yeah.
And most people have an awareness of problems. Some people don't, but the vast majority do. Because hip replacement is so ubiquitous, they almost, most people know someone who have had one.
Yeah.
It's really, really important part of the conversation.
Yeah, absolutely. And I think as you've alluded to, it's also very much a personal conversation between each person and their surgeon. And as ever, these videos are by no means a replacement for any of those conversations, but hopefully something that will help to add to that and sort of touch on some of the general points. But a crucial thing around this is finding and thinking about and considering how these potential risks and complications would impact on you personally and your lifestyle and the things that are meaningful and important to you as an individual.
Absolutely. Yeah.
And I guess it's also worth highlighting that, and I know this is something that's been raised in feedback and in messages that we've had through from people using the Joint School app, and as ever, please do keep sending them in. But I know that people who are looking for information online and forums and so on, you may well find quite a lot of negative stories out there. And I think often on the online forums, there may be a bit of a overbalance towards some of the horror stories and things about risks and complications. And that's worth bearing in mind as well, that there is, and hopefully we can add some balance to that by exploring this topic in the way that you would go about it in clinic.
Yeah, I think that's really an interesting comment, actually. I think there's a problem with when you talk about complications, you say, well, there's the percentage of this happening is such and such. But if it happens to someone, it's 100% of their life. And some of these complications are really severe and they can have a devastating impact on people's lives. And if you imagine you are that patient, you're going to voice those opinions. So, on forums and things like that, if you have people that have had problems, had bad experiences and have complications, that's what it's like, and they're going to voice those opinions. But I think it's important that you keep in perspective, that patients keep in perspective, what's the chance of that happening to me? And balancing that up against the very good chances, and we'll talk about that, what the sort of percentages are. What's the chance of having a good outcome versus what's the percentage chance of having that bad outcome?
And of course also in the cases where a complication has occurred or some negative experience has arisen, there are many different treatment options and things to address many of those complications as well, which could, I think, be a separate conversation and session in its own right. Indeed.
Yeah, no, absolutely. I mean, many of us, spend our lives, doing redo surgery, revision surgery, and that is about dealing with the complications of surgery. And there are many different operations and many different devices and implants that are designed to cope with the problems that have occurred.
But if we zoom out a little bit and go a bit more generally, and perhaps the best way to begin would be to sort of, well, hand it over to you and see how would you begin this conversation in clinic, because it is a bit of an uncomfortable and it can be a bit daunting and everyone is a bit different. So yeah, how would you go about this tackling this topic?
Yeah, so I think it really starts sort of after you're comfortable with the diagnosis of the patient. So you know that it's the problem is the hip. The hip is significantly destroyed. That means that a joint replacement is going to be an appropriate thing to do for this patient. And then you sort of that your head switches and it's not a diagnostic mode anymore, and it's all about treatment. So you talk about conservative treatment options. What pain relief they've taken. Activity modifications, physiotherapy, possibly injections can sometimes be helpful for some patients, or surgery. And then, when I start talking about surgery and hip replacement, I start with what I think is sort of the most important things for them to remember. So I say, whatever we say about risks, later on, I want you to really remember that there's a 90 to 95% chance of you having a really good outcome. And that hip replacement is one of the most reliable operations. You compare it to all the other operations that are done on the bowels, heart transplants, brain surgery, all these kind of things. Nothing is as reliable as a hip replacement, perhaps apart from cataracts.
Yeah.
But it is really, really reliable. So 90 to 95% is the sort of figure that I try and get people to remember. But obviously the flip side of that is that there's, probably a 5% chance of it not going perfectly well. So 5% chance of perhaps having ongoing issues or specific complications. And then I'd kind of, then continue on to talk about what those specific complications might be.
Yeah. Well, and before we go into the specific complications, I think just on that note, I think many people will say or have referenced the hip replacement as one of the most successful operations, and I think one article called it the most successful surgical procedure of the 20th century. And since then there have been more innovations and improvements and so on. But so in terms of the more specific complications, then how do you organize that and break that conversation down into digestible bits, so to speak?
Yeah, so I suppose I tend to start with saying things like one of the things that we as surgeons really worry about and do a lot to try and reduce risks about are things like dislocation and infection, which most people have heard about.
Yeah.
So let's say talk about infection. So the chance of that happening is probably about 1%. So 1 in 100 patients might have an infection afterwards, and that could occur quite some time after surgery, not necessarily straight away. And I mentioned that we do an awful lot to try and reduce the risks of having an infection in the first place. So we give antibiotics intravenously at the time of surgery and sometimes afterwards. We might put, if it's a cemented hip replacement, there might be antibiotics in the bone cement. The operating theatre we work within is ultra filtered air, so it's sterile air in the operating theatre to try and reduce those risks. The surgeons will often wear a kind of a spacesuit, to try and exclude skin scales from the surgeon, and all those things are all about trying to reduce the risk of infection. Patient may have been given skin washes beforehand to try and decolonize skin. They might have had a swab for MRSA before to make sure they're not a carrier of MRSA. All these things are about trying to reduce that risk. But even with all of that, the risk is still there, and it's probably about 1%. And the problem with infection is if you get infection in a joint replacement, the bugs sit on the metal or on the plastic or on the ceramic or whatever it is, and your body can't get rid of that infection. And giving antibiotics won't get rid of that infection because there's no blood supply to the metal. So your immune system can't access it. So you might have antibiotics and that might suppress it, but ultimately if it's a real deep infection on the implants, then the only real option then is surgery, more surgery, to take the implants out, to wash out the area, potentially then put a new hip replacement in at the same time, and that would be called a one-stage revision, or to take the implants out, put a temporary hip in, or even no hip, and then leave that to heal up, and then go back some 6-8 weeks later when everything's settled, and then put another hip replacement in. So So real deep infections do sometimes lead to the necessity for further revision operations.
And you mentioned that the sort of overall the risk of an infection is roughly 1 in 100. Where in the cases where an infection does occur, within that group, what is then the risk of that going on to requiring a revision for a deep infection?
Yeah, so I think I think the 1% is the sort of deep infection risk.
Right.
Okay, so you can have superficial infections. You know, the wound might just look a little bit red at some point. You know, you might see a GP and it might give you some antibiotics. You know, and they give you some tablets for a bit, and it settles down. You know, that might be a superficial sort of, which is a much less serious infection.
Mm-hmm.
But what we're really talking about and what we're really worried about is the real deep infections, which would, the vast majority would need revision surgery.
Yeah.
But the success rate of revision surgery in that situation is very good. So again, there's a 90% chance of getting rid of the infection
Mm-hmm.
with revision surgery for infection.
Okay.
So obviously that, if you do your maths, that means that there's a 10% risk of infection when you're doing a revision for infection, which is 10 times higher than it was at the beginning.
Yeah.
So, but yeah, so there are treatment options, but I suppose this conversation now is probably going a little bit further on than we would do in a normal clinic situation, because we've got the time. But I think that's the value of this, is that we can perhaps go a bit deeper.
Yeah.
And so a patient might say, well, what happens if you can't get rid of the infection in a revision? We might need another revision. And then another revision, and it might not come back, and then you might have to have, take all the implants out completely and not put any more metalwork in there. Or it might be a multi-drug resistant bacteria that you get an infection, and that's very difficult. So, ultimately, in the really, really severe cases, it can be that you can't put another hip in, and the patient ends up, with what we call a pseudo, which is short for a pseudoarthrosis. And patients actually can be reasonably mobile. Obviously, they're left with quite a short leg on that side, requiring mobility support with crutches or a Zimmer frame. But it's not necessarily meaning that they have to be in a wheelchair all the time. But the chance of getting to that stage is really, 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 really small. But we do see patients that have been in that situation.
Okay, well, so that's infection covered.
That's infection, yeah.
Infection covered in some detail.
So then I'd probably go on to talk about dislocation.
Okay.
So dislocation is when basically the ball and the socket, so the artificial ball and socket, the ball pops out of the socket. So it's not designed to do that. It's designed to stay in place, obviously. But if the patient, fell awkwardly or twisted, then there is the potential that might happen. Now, again, the risk is about 1%, maybe even a bit less than that. And oftentimes it's related to the position that the implant's been put in. So, down to where they were positioned at the time of surgery, and that in combination with the way the patient moves. And sometimes it's a truly traumatic event. Someone falls down the stairs or something like that, and they get their leg caught, then obviously they can injure any joint. But sometimes it can be something quite innocuous, like just reaching down to sort of tie your shoelaces or something like that. But most situations, if it dislocates, that's quite a sudden event. Obviously, it's painful. You can't walk, so people would end up in A&E essentially, and then we'd have to have an anaesthetic to put the hip back in. So generally, with a manipulation, not opening up the hip, but with the manipulation, you can most times get the hip back in.
So no surgery, just kind of position.
Yeah. So an anaesthetic, but no kind of open surgery. And the vast majority of times, that wouldn't go on to then be a recurrent problem, and the patient would recover, go home, and then get on with things. But in some cases, it may go on to be a recurrent problem, and the hip then keeps dislocating. And then it might be that some more surgery needs to be done on the hip, either to readjust the position of implants, or to change implants out for some other design that might be more stable. So dislocation again can lead to revision in some situations.
And I guess here we're touching on a subject that I know can cause some confusion, particularly as, by and large, I guess many hospitals and many surgeons seem to be moving away from using what's called hip precautions, but
Mhm.
they're still in place in some cases. And I guess that's originally, I think one of the main things they were there for, I guess, is to limit the risk of dislocation.
Yeah, so I mean, that's an interesting topic you
Uh,
touched on there, and it's a bit of a minefield if you
yeah,
think about it actually. So yeah, hip precautions are these things that people are often instructed to do after surgery, and the common things are to sleep on your back, not to lie on your side, not to cross your legs, and then not to bend the hip more than 90 degrees. To kind of bending down to touch your toes and things like that. And that might be anywhere from maybe 6 weeks or even 12 weeks in maybe more extreme examples. And that actually it's a historical thing. So at Wrightington, where I work, that's where John Charnley started doing hip replacement. And initially they had patients in bed for a week after surgery, even in plaster with a stick between the legs, and then gradually got more kind of accelerated rehab. But the hip precautions kind of stayed, and we actually are in process of doing a randomized trial about hip precautions versus no hip precautions, and does that actually reduce the risk of dislocation? Does it affect the functional outcome of patients? Because many patients find it really hard to sleep on their back, and avoid doing those things. It's very, very difficult. So the bottom line is there's very, very little evidence that hip precautions actually do anything. But yet everybody's very reluctant many
yeah,
people are very reluctant to withdraw because the consequence of this case is significant. It's really painful for the patient. Obviously, everybody wants to avoid that. So to withdraw something can be very difficult. But you're absolutely right that the trend is away from that.
Having said that, though, I'll flag for anyone watching this video who has been given hip precautions: always follow the plan from your surgeon and your team.
Yeah, absolutely. So obviously a lot of the post-operative instructions that patients are given are very patient specific. So it might be that there's a specific reason why you've been told to do these particular things. So yeah, so what we're talking about is a very generic, general sort of discussion rather than any specific advice to any one individual.
Yeah. And I think a related conversation that I know also causes some confusion among people who are thinking about having a hip replacement, or indeed are getting ready for a hip replacement, is about the different approaches. And we've done a separate session on that, and we could indeed speak at some length about the different approaches. But particularly in terms of risks and complications, do different approaches come with different risks and complications?
Yeah, I mean, in general, I mean, around the hip, I suppose you can broadly say there are maybe three approaches. So there's a posterior approach, the sort of the direct lateral approach, and an anterior, or what people tend to refer to as a muscle sparing type approach. And historically, people would have said that, well, maybe the posterior approach has a slight higher risk of dislocation, although many recent studies have shown that maybe isn't the case. A direct lateral approach, certainly takes more muscle off the bone to do the approach, and there's the risk of that not healing back on, probably a higher risk of maybe limping after surgery with that approach. The anterior approach, which is sort of gaining a lot of popularity, particularly in America and other parts of the world, very popular. That's very obviously very good approach, but maybe there's a slightly higher risk of quite minor nerve issues with that. There's a very small nerve that supplies the skin sensation at the front of the thigh, and that's quite commonly, not it can be quite stretched or whatever afterwards, and so a bit of a numb area at the front, is a not uncommon, complication following that. And one of the other issues with that approach, particularly in someone who's not really, au fait with it, or is perhaps learning or whatever, it can be more difficult to get exposure and to get the right angles of the implant. So complications such as fractures around the implants when putting them in might be slightly higher, in some studies. But again, it's very specific to the surgeon, the unit they work in, how they've been trained, what they're familiar with, and the patient that's there in front of them. So these things are very, very general.
Yeah. And then, so I guess moving on then perhaps to another more general topic, which I think most people will encounter as part of their pre-operative planning, and indeed in terms of the post-operative protocols as well, is around the risk of blood clots.
Hmm. Yeah, so again, blood clots is a little bit like infection, that we do a lot to try and reduce it.
Yeah.
So people will, generally be given, some kind of drug, whether that's a tablet, whether it's aspirin, or one of the kind of more modern, newer sort of blood thinning tablets, or injections even of some form of heparin, and they may have to carry on that after surgery for some period. They may also be given sort of TED stockings, the white compressive stockings, which can be very uncomfortable and hot, particularly in this kind of weather. Can be quite unpleasant. But those kind of things are all given to try and reduce the risk of blood clots. And obviously, one of the main things actually that we do is get people up early. So I referred earlier to historical data and length of stay. So in the 60s at Wrightington, the length of stay after hip replacement was 30 days. So now it's like it's getting down to 3, and with day case surgery, we're doing that as well. So getting the patient up and getting them to move and contract their leg muscles, particularly their calf muscles, is really vitally important. And there can be other things like mechanical stimulators, foot pumps, that are used both during the operation on the non-operated leg, and then afterwards as well. Back on the wards, some units will use those foot pumps. Many patients find those quite annoying in the night because they keep squeezing and letting off little gases of air and things like that. So yeah, all these things that are used to try and reduce those risks.
Okay. So I think we've covered infection and dislocation and blood clots, and we've touched on how risks can vary with some of the different approaches. Something else that is often asked about, I think, certainly from what we've seen on the forums and with the Joint School app and so on, is around squeaky hips, or like hips making a noise or clicking afterwards.
Mm-hmm. Yeah. Okay. So that's something which is actually quite specific to a specific type of hip replacement. So it's pretty uncommon to get noises from a hip if it's not a ceramic on ceramic hip. So by ceramic on ceramic, what we mean is that the ball is made of ceramic, and the liner in the socket is also made of ceramic. So the two things that are rubbing against each other are both ceramic. Okay. Now, sometimes if the position is slightly abnormal, then basically the ball rubs on the edge of the socket rather than being nicely covered by the socket, and that's something which can sometimes lead to a bit of a squeak. Okay. Obviously, squeaking is a very variable, so it can be something that might occur really infrequently. It might be something that occurs maybe when a patient just leans down to tie the shoelaces in the morning, but then after that it doesn't happen again. Or it might be so severe that every time they move and every time they walk, it constantly squeaks. And I'm sure many people have seen on the internet, there are videos of these horrendous squeaking hips. And obviously the worse it is, the more likely there's a serious problem with the hip. So if it's just a minor, really not inconvenient kind of noise, and the x-rays all look fine, then that's probably not something to worry too much about. The chance of it happening, if there's a polyethylene liner, which is probably the more common situation, the hips just don't squeak in that situation.
Right. Okay.
If you do have a ceramic on ceramic hip, you might say, well, what's the chance of it making noises? And it can be higher than you might expect. We actually did a study which we published, where we sent questionnaires to patients who'd had that type of hip, and actually found that probably about 20% of people had experienced some kind of noises from their hip. Right. And interesting, out of that group of about, I can't quite remember the exact numbers, but around about 300 patients, we hadn't had to revise any of the hips for squeaking. So they're all relatively minor. But there is that sort of background level of intermittently, that they have these noises.
Right, but I guess within that group there would have been potentially a bit of a range as well, in terms of how severe that squeak or the noise was.
Yeah, that's right. Yeah. I mean, although we didn't really have anybody that had any kind of severe noises on normal walking. It's all just kind of intermittent.
Okay.
Yeah.
Okay. And you mentioned that a squeak or a noise could be related to the positioning of the implant, or malalignment, problems with the position with the implant not quite being sort of in the optimal position. What other issues could that cause?
So
beyond squeaking and noise and things like that.
Right. Okay. Well, maybe perhaps I'll just sort of another thing actually. Maybe before we get on sort of past that squeaking issue.
Yeah.
So I think one of the important issues around squeaking is that if you've had a really good hip and then suddenly it starts squeaking quite a lot.
Oh yeah.
That's a really important kind of flag, I suppose. A new symptom. You want to get that checked out because there is a chance that a sudden new squeak might be related to some damage to the ceramic. So like a chip or even a fracture, can then really cause quite a lot of noise within the hip joint.
Right.
So if you suddenly have that, then that's something that you'd want to get checked out. But most people would, because if you've had a hip replacement, it's doing fine, and suddenly it starts making noises, you're going to go, crikey, I need to go and see my GP or my doctor.
Yeah.
It's pretty obvious.
Yeah, no, that's good flag. Good flag.
Yeah. So you were asking about the if the implant position is kind of a little bit out, what the effect of that? Well, obviously, if the kind of the stem, so the bit that goes into the femur to the thigh bone, if that is kind of too long, if you like, then that can lead to the leg being too long. So a leg length discrepancy is what we call it. It is something which can occur after surgery. Now, most surgeons would try and measure that during the operation. They would look at the x-rays and measure the x-rays beforehand and know kind of what they're planning to do. But sometimes you have to balance up this risk of dislocation against the length. So if you put the hip in the right length, it might be really quite sloppy and really a bit unstable. So you might have to make it a little bit long on purpose to make sure that it is appropriately stable. It's pretty uncommon for the legs to be, if that was an issue after surgery, pretty uncommon for that to be more than about 1 centimetre. And you'd be really surprised at how many people have that level of difference even before the operation.
Right.
And don't notice it.
Right.
It's surprising how often you see a patient in clinic, even without any arthritis in the hip, and you measure the leg lengths and it's 5 mil difference, 8 centimeters sometimes. Like, I've never noticed that, but my trousers always seem a bit long on that side. But nobody's ever noticed, nobody's mentioned it, So leg length, can occur afterwards. Sometimes it's not noticeable, but in some patients, they notice a really small difference. I mean, it's remarkable. Sometimes you might have someone who has just a 5 millimeter difference, and they really notice it. Whether that's because of the effect it has on the spine, if they've got a bit of a stiff back, it tilts them over a bit, and then they have to compensate, and then they really struggle with that. So there's lots of factors going on there. Most of the time, if it's a problem, you can simply just have an insert into the shoe, so an insole to lift up the other side to balance them out, and that can be quite successful. But obviously, if it's significant and it's a really big difference, and again, it might be something that the only way to resolve that is to revise the hip, to take the implants out. So leg length difference. If the hip is, we talked about, if it's too long, if it's too wide, then that can stretch the muscles quite a lot, and people can have quite a bit of sort of pain at the side of the hip, really pain on lying and things like that. So that can be a problem. On the socket side, if the angle of the socket is wrong, that can mean that maybe the hip is more likely to dislocate, because again, the ball isn't covered over by the socket as much, and it's more likely to pop out.
Well, and on the topic of leg length discrepancy, I've got the impression, I don't know if this is held up in research and in your experience, but I've kind of got the impression that it's not uncommon for people to feel as though the operated side is longer after surgery, particularly if there's been quite severe arthritis on that side, but that it's actually a return to sort of more of a natural anatomy, that it kind of settles over the first weeks and so on of recovery.
Yeah, absolutely. It can definitely be a dynamic thing that changes with time. So particularly if you have someone who's had, really quite severe arthritis, so the hip is actually shortened. They've lost bone in the hip and it's shorter before. The muscles then also kind of shorten up a little bit, and then when you put it back into the right length, actually you're kind of stretching out those muscles, and actually that the patient can kind of feel that, they were kind of comfortable with it, not comfortable because it had pain obviously, but kind of got used to that difference. And now you put it to the same length, they kind of feel a little bit overbalanced. But also there's this other issue where if the muscles are then very tight, the leg can be much more comfortable in a position where the knee is outwards, so we call it abducted, because that takes the tension off the abductor muscles, the gluteal muscles. So if you've got too much tension, then the leg can be more happy to be kind of out to the side. But then because you can't walk like that, then what you do is you bring the other leg over to meet it. And then you end up with a very, the pelvis goes from like this to like this. And then that makes the leg look, massively long. So sometimes, when I've seen patients in clinic and they say, well, it's all been great, Dr. Board, but my leg's really long, and I went to see the physio and they said it was 2 inches long. It's like 2 inches is like almost impossible to do in surgery without doing something really strange. So when you hear that kind of story, you think that's a pelvic ubiquity problem.
Right.
Yeah, that level of difference is because the pelvis is really twisted.
Right.
And so it's that kind of thing which can really settle with time. So if it's a stretching out of the muscles are pretty good if they have been the normal length, and then they've sort of contracted a bit because of shortening, they do quite well, stretching again. So you put it in, the leg goes over to the side, they feel it's really, really long, and give it enough time and it will come back. The danger is that someone gives them a shoe raise to try and compensate, and they end up fixing in that position.
Right.
So then 6 months later, there's no way you're going to get that hip back, in the right position. So it's quite important to identify those patients who have that problem, because stretching exercises, working with your therapist is the way through that. And if you kind of have a shoe raise too early, then that can be a negative thing for the patient.
Interesting. Okay. Well, and so if we then move on, clearly we're staying around the hip joint for the duration of this conversation, but if we move on to other implant related issues that can potentially occur, you mentioned fracture, sort of a break in the bone. How would you, what sort of points would you touch on there typically in a clinic? And I guess we can expand on as you said here.
Yeah, so I mean, obviously, I generally say that whenever you operate on bones, obviously there's a risk of fracturing them. Using power tools, you're using mallet, during the surgery, and there is a risk of fracture. It's pretty low, like 1 in 500 or something like that sort of kind of risk of having a problem. If there is a problem during the operation, and you notice it, obviously, you do something about it. So you sort it out at the time, whether that's you need to fix the fracture, or whether that means you need to use a different kind of implant. That's resolved at the time. If a patient has a fall after their surgery, kind of any time after surgery, we talked about falling down the stairs or whatever, if you injure yourself severely, there's a chance you might fracture the bones around the hip replacement, in the same way that you might fracture the bones on the other hip. But the kind of fracture you get is different because of the hip replacement being there. I mean, it's quite common that a fracture around a hip replacement would require an operation to kind of put that back together and fix it, or even to revise the hip to get the patient back walking again.
Right. Okay.
That does, often that's the chance of that happening can sometimes go up as the years go by. So if there starts to be a problem with a bit of loosening, or the bone becomes a little bit weaker, then the chance of fracture starts to go up a little bit.
Yeah. And I guess as with all risks and complications, it will also be dependent on personal factors and bone strength and
absolutely. Yeah.
Okay. And then I guess another thing that will vary quite significantly from one person to another might be around allergies and reactions.
Yeah, so allergies around hip replacement is a little bit of a thorny topic, really. Obviously many people are allergic to metals like nickel. It's a common thing. I can't wear cheap jewelry, as an example of what people might say. There is actually very, very little evidence that that kind of allergy is related in any respect to an allergy to implants.
Okay,
Just because of the way the immune system works. So, I kind of wouldn't want to go into that in any more detail, really. But, there are definitely some patients that have, had, big, significant reactions, anaphylactic reactions that have come in, they've been tested, they've had patch testing, and there's a list of these are the things I can't have in my hip. It might be, cobalt, chrome, or something like that, and there are implants that are made from other materials. So, if I have a patient out in the clinic, they say, well, okay, well, I'm actually allergic. I've had these problems. I'm allergic to cobalt and chrome. Okay, well, that means we'll only use titanium in the hip. And then they're not allergic to that. So that's kind of my approach. But again, it's very, very patient specific, and obviously surgeon specific as well.
Yeah. Okay. Another topic that I know some people are particularly concerned about is the risk of potentially needing a blood transfusion, either during or soon after the operation.
Yeah. So again, we do a lot of things to try and reduce the risk of blood transfusions. Obviously, you use diathermy during the operation. It's very, very common now, and in the recent NICE guidance about hip replacement, it talks about using a drug called tranexamic acid, which is very commonly used in surgery now, and it's given at the time of the operation, and it significantly reduces the risk of needing a blood transfusion afterwards, reduces the blood loss. So everybody should really be getting that. But the chance of having a blood transfusion is pretty small. So again, maybe it's kind of 1 or 2%, in a lot of units. There are certain things that we can do if patients have a specific, bleeding risk, for example. We can use things like what we call cell salvage. So we use suction during the operation to sort of take away any blood that accumulates. And we have machines where that can go, and it gets filtered through a machine in the operating theatre, pumped into a bag and then given back to the patient. So in the really bigger operations, in the revisions and things like that, where there's quite a lot more blood loss, we would routinely use that. So the patient's own blood then gets recycled and given back to them.
And so I think that's blood transfusion covered. If we move on then to something that you mentioned when we touched on different approaches having different risks, and you mentioned then the potential of sort of irritating or damaging nerves. And sort of if we do that conversation, but more generally, what sort of are the risks of nerve damage in a typical hip replacement, and what could that cause?
Yeah, so I mean, classically, the risk of a proper nerve injury after hip replacement is much lower than the other risks we talked about already. So rather than it being sort of 1 in 100, it's more like 1 in 1,000.
Yeah, we're getting close to the bottom of the list here.
Yeah, exactly. But it's really important to talk about, because the consequence of a nerve injury can be really debilitating and really severe. So obviously nerves, they give you sensation in the skin, and they control the muscles and movement. So a nerve injury could leave you with numbness or weakness of the muscles. So there are a couple of the big nerves that run across past the hip joint. So at the back of the hip, there's the sciatic nerve, from sciatica. So damage to that nerve can lead to numbness in the foot, and to weakness of the foot, so a drop foot. If there is a nerve injury, it can recover. It obviously depends what's happened to the nerve. So if it's just bruised or it's stretched, or sometimes nerves can just be really, really sensitive. People say that the nerve. I just looked at the nerve wrong. So nerve injuries can range from anything from just a little bit of numbness, which resolves after maybe a couple of months,
Mhm.
or to, numbness and weakness, which, takes 2 years to get better,
Oh, okay.
because nerves can be really, really slow to recover.
Mhm.
Or it might be that it doesn't recover, and the patient is then left with, significant numbness and weakness. Um, there are, you can do surgery to repair nerves if a nerve has been, cut, or a suture, a stitch around the nerve, or something's, physically pressing on it. Then, that might need to be explored,
Mhm.
with someone who does operate on nerves.
Mhm.
So there are things that you can do if that's a problem. One of the sort of what we feel one of the sort of cardinal signs for a really worrying nerve injury is where there's a nerve injury with pain.
Right.
If
Okay.
the patient has pain in the sort of distribution of the nerve, then it's likely there's something is really still irritating that nerve. If it's just numbness with maybe some weakness, then that's maybe not something that needs kind of an emergency operation to sort out.
Right. Okay. Okay.
So that sciatic nerve at the back, and at the front is the femoral nerve, and the femoral nerve, supplies some of the sensation at the front of the leg in the thigh, and the quads muscle, so the thigh muscle at the front. So if you have, weakness of that can be difficult, to straighten your leg out, and that's
Yeah.
important when
Yeah.
you're walking.
Yeah.
Obviously, you need that power. You need collapses when you put weight on it.
Yeah. Yeah. Yeah.
So again, the approach, which way you're going in, depends on which of those nerves might be at high risk, and
Yeah.
also it's obviously patient specific. So, one example of somebody who might be at a higher risk of having a nerve problem is someone who's got a really severe problem with the leg. Maybe it's very, very short,
Mhm.
or it's been dislocated. Their own hip has been dislocated maybe since birth or something like that. So it's very, very short, and you're having to kind of stretch the leg to get the length back. So we know that the nerves can be sensitive to that stretch. So the shorter it was before, perhaps, the more likely to have a problem with nerves afterwards. But obviously we are aware of these issues, and then you would counsel the patient appropriately, say, look, for these reasons, you're at slightly higher risk of this problem, than the routine.
Right. Okay. Okay. And you mentioned pain in relation to the risk of nerve damage, but of course discomfort and pain is likely to be a factor um, after hip replacement. And I know for some people there's a concern that, well, what if the pain after surgery is actually worse than the pain I'm experiencing, than the arthritic pain I'm experiencing before the operation? And
Hmm.
what kind of things would you say when asked that kind of question?
Yeah, so I mean, I think if the hip pain is because of hip arthritis, or a hip specific problem, which is which causing this really bad quality of life issues, and the diagnosis is correct, that's where the pain is coming from, then a hip replacement is a really, really uncommon to have significant problems with pain afterwards. When we see patients in the clinic that have had hip replacements, and the x-rays look great, so, well, there's nothing wrong with this hip replacement on an x-ray, but the patient still has pain. The things that are running through your mind are, well, is the pain coming from somewhere else? So was it actually coming from the spine all the time? Problems with the spine, slip discs can cause pain into the hip area, referred pain. So it might have been that was actually the main cause at the beginning, and the hip wasn't never really the problem, even though they might have had some arthritis. Equally, maybe it's a knee problem, probably a bit less commonly. Is there a muscle problem around the hip that's causing the pain before the surgery? So kind of inappropriate surgery in inverted commas, and by that what I mean is actually that although they had arthritis, that wasn't the main source of the pain before the operation. So you do a hip replacement, and the pain they were getting from arthritis goes away, but they're still left with that other pain because it was coming from somewhere else. So that's kind of one group of patients. So being very clear and certain about the diagnosis before surgery is obviously important. And then you have some patients who have chronic pain. Chronic pain is a really difficult problem, very difficult to understand, very difficult for a lot of clinicians to understand, and difficult for patients to understand. So you might have someone who doesn't really have much arthritis. You can just about see something on X-ray, but they have really, really severe pain. Maybe they've had it for ages. They've had lots of injections. Maybe they've had some arthroscopies or something like that. And actually they've got really severe pain that's sort of out of proportion with what you can see on the X-rays. And it might be in patients like that actually their nerve fibers are not working properly.
Right.
And their nerve fibers are firing as if they're being stimulated by pain. So they're feeling pain. It's not, I'm not saying it's in the head, but the nerves are firing to say, I've got pain, but actually there's nothing wrong in there which is causing that. So if you then replace the hip, you're not replacing all the nerve fibers. So the hip replacement can look fine, but actually the nerve fibers are still firing. So you've still got pain. So that they're quite rare, those patients, but there are some patients like that. So that's important to be clear about, this relationship between the actual physical or pathological problem within the hip and what problems it's causing. And then obviously you've got patients who've had they've had a hip replacement, and everything was great. They got rid of that pain that they had before, but then suddenly they've got a different kind of pain. And it could be, sometimes we see patients who have tendon irritation on the implants that can occur. So particularly in the socket, there's a tendon at the front of the hip, the psoas tendon, which is one of the hip flexors, that can sometimes rub on the front of the socket if the socket is sort of jutting out, if you like. It's not covered by bone, and that can be really painful and kind of limit patients in terms of their hip flexions, are getting out of a car or going up a curve, going up a curb, going up stairs and things like that, quite specific symptoms. And again, the x-rays might look completely normal. So, they might go back to the surgeon and say, well, it's okay, but I've now got this other pain. It's really debilitating. I can't join my rambling club again. The x-rays look normal. They do blood tests, look normal. The bone scans look normal. Everything is fine. So there are these sort of specific, things that can cause pain that we need to be aware of, that people don't get missed, essentially.
But I guess it's also worth again flagging that for most people, the arthritic pain is successfully treated by the hip replacement.
Absolutely. So that's why at the beginning, so I said at the beginning of the conversation, there's a 90 to 95% chance that you'll get excellent resolution of pain. You'll get really good quality of life back. And then after all of this, discussion about all the horrible things that can potentially go wrong, patients they were quite happy at the beginning, and now they're, oh, crikey. I kind of tend to come back and then at the end and say, we've talked about all these percentages. What I really want you to try and remember, if there's a 90 to 95% chance of it going really well and you'll be fine, and there is this, there's this small chance of a problem. Most of the problems that can occur, there are treatments for. Some of them might require surgery, but the surgeries can be quite successful. There's a very, very small chance that you will genuinely be worse than you are now, but it's possible. So,
but I guess before we highlight that and sort of to sign off, we do need to touch on the most horrible risk and complication, and the question of the risk of dying from a hip replacement.
Yep, absolutely. So I think that's something that sometimes people shy away from talking about. I do talk about that. I probably don't talk about it with every single patient, but I probably should. Certainly in the clinic, I know when we consent patients, in terms of that period when you might fill in the consent form, that's written on there. But I when I talk about risk of death to patients, I generally say, obviously there's lots of bad things happen. Sometimes I'll say, what's the worst that could happen? And that's my kind of link to say, well, obviously the worst thing that happen is you could die. But then I said, but you could die, coming in the car on the way to the hospital, or on the way home, going on an airplane, crossing a road. Every day there's risk of that all around us all the time, but we kind of choose to ignore it because you can't think about it all the time. But they need to be aware that there is a very, very small risk of that. And that's kind of, if you talk about figures, it's kind of 0.01%, so it's pretty small risks. And generally, to go one step further, I suppose, a lot of that is, those cases might be related to the things we talked about. So, blood clots, blood clots in the legs can travel into the lungs as a pulmonary embolus. That's one of the causes of death after surgery, any surgery. Anesthetic complications, general medical issues like, heart problems afterwards, stroke, breathing difficulties, all these kind of things. Those are the kind of things that tend to lead to those kind of serious medical complications.
Yeah, yeah. And we will be doing a separate session on anesthetic, on anesthesia and joint replacement generally, and we'll touch on the anesthetic risks more specifically in that interview. And we've gone, so I think we've done a thorough overview of some general risks and some more specific risks around hip replacement surgery. And now, of course, here we are in 2020, and there is this new factor of coronavirus and COVID-19, and how that impacts things. What are you discussing with your patients who are being booked in for surgery now in terms of what that might mean? And of course, we need to flag for anyone watching this video beyond the summer of 2020 that things may well change.
Yeah, absolutely. Yeah, so it's obviously it's a really important factor at the moment, and we are in this time where we're restarting, to do planned surgery now. We are talking specifically to every patient, about the risks of coronavirus, COVID-19. So, specifically, we tell them that if they have an operation, obviously there's a risk of them getting the virus, during their inpatient stay or afterwards, or having it beforehand. So they will have, they'll be instructed in some form of isolation before the operation. The guidance on that is kind of changing. So as you say, relevant to time. So it might be 2 weeks of isolation before surgery, or it might even just be 72 hours for some patients. But there would be some period of isolation beforehand to make sure that they don't have it before the operation. And most patients would get tested for COVID as well before the operation. So that as far as you can do, that they've not got it at the time. And then afterwards, they would also be advised to isolate, for a period after the surgery as well, because we know that if you get it after an operation, it can also be risky. So that's the actions the patient has to take. They have to take it really seriously and isolate before and afterwards, look after themselves, etc. And that can have quite a lot of impact on someone who's working, for example, that they might be told they've got to have 2 weeks off before the operation as well now, and they weren't expecting that. So it's important. In terms of the risks, that's much harder to sort of put into figures, because there's not a lot of data on it, and it's probably changing as we speak. But in general, the data that we do have probably suggests there's probably around about a 2% chance of getting COVID, by having an operation. And then if you do get it, the risks are obviously, everybody knows what COVID does to people. It can be really bad and can put you in ICU, and people die as a result of that, in some cases. So taking that 2% risk of getting it, if you do get it, there probably maybe around about a 20% chance of dying because of it. So it's quite serious. Having it around an operation time is probably worse than having it at another time. So it's really important to have that kind of conversation. And it's also important to stress to patients that it's very patient specific, as we've already talked about. So the patients that are, that are higher risk are patients who are elderly, patients with comorbidities such as diabetes, overweight, multiple medications, kind of problems such as this, all the normal risk factors that have been talked about in the media are all there. So the risks are different for different patients, but as a broad brushstroke, those are the kind of figures that we're sort of talking about at the moment, as you say, in sort of mid-August 2020. Those are the figures that we're using to talk to patients. And many patients would say, well, the response from patients is very different. Some patients would say, oh, well, I know someone that had it, and I can manage. I'll wait. I really that's the worst thing. I just don't. I just want to switch off from there. I'll wait. I'll just wait and not have my operation. Thanks very much. Other people will say, well, actually, is that going to change? So what I think this is an interesting question. So if I put my operation off for 6 months, what's the risk then going to be? Well, it's probably going to be quite similar. We're seeing that there are some areas where there are second surges. Until we get a vaccine, which is across the whole population, these risks that we've just talked about are probably going to be there or thereabouts for quite a long time to come. And I think that's really important you get that across to patients, because they might think, oh, well, I'll wait for 6 months and then it'll go away and it'll be better. But actually it might not be. So they need to sort of balance this up into the normal risks of thinking about surgery. So I think that's an important factor. And the other thing that people have often brought up to me is, so we're restarting surgery now. You think they kind of quite insightfully saying, yeah, please, I want it now because I think you're going to have to stop again in the winter, which is possible, which is a possibility. Yeah. So sort of taking that opportunity to have their operation when it's available. But yeah, all these things are changing, quite rapidly, obviously.
Yeah, of course. So for those patients of yours who are now booking in for surgery, and you mentioned some of the key things that they may need to do to reduce the risk of COVID-19. But sort of if we kind of zoom out a bit more and go back to sort of very more general terms, what and kind of summarize the sort of the run of some of the risks and complications that we've covered. What are the key things that one can do as a patient to try to minimize the risk of complications?
I think I'd say probably you might want to edit this out, but probably the key is choosing your surgeon. I have to say that. You ask any joint replacement surgeon, we discuss about implants, things like that, and they say, what implant would you have? Well, I'd choose my surgeon, and let them do what they do normally. So yeah, like I said, you might want to edit that bit. But yeah, so in terms of patients, what can patients do to minimize the risk of complications? Well, it's about being fit and healthy. So trying to maximize your activity, obviously within the pain that you have. If you can get out and be mobile, that improves the blood flow in the legs, reduces the risk of blood clots. Anything you can do to kind of strengthen the muscles around the hip will aid and speed the recovery afterwards. Healthy eating, obviously, having a healthy balanced diet, not smoking. Smoking has a risk for medical complications. Equally, appropriate amounts of alcohol are obviously important as well. And then, engaging with the process. Yeah. So, listening to the advice that's given. We talked about hip precautions. If you've been told to follow those, then you should follow those. Engage with if you're having physio afterwards, which some places would have, to do those exercises, to not overdo things. So, sometimes we have patients that, feel that are indestructible afterwards, the pain's gone away, and they want to just get out and do everything. So, you see them afterwards, a few weeks after surgery. Oh, yeah, my hip's brilliant. Yeah, I climbed the mountain in the Lake District of the weekend. You think, it's a bit, a little bit early. I kind of tend to focus patients on that first kind of six to 8 weeks of after surgery, in terms of things healing up, particularly if they've uncemented implants used, where the bone has to grow into the implant. Yeah. If you overdo it, you can get a bit of movement, and that can jeopardize that fixation. So to not overdo it, in that first period, enables good fixation, and then when that's done, then they can just go and do whatever they want. So I say, look, just take it easy, because you can spot the patient who's going to go off and do mad things. Obviously everybody's different. We've already said that, but some people will be just chomping at the bit. So you say, keep it calm for just 8 weeks. Do that for me, and then you can do what you want. And I won't tell you not to do, X, Y, Z, skiing, cycling, triathlon, or whatever it is.
So giving it time to heal, gentle little movements to keep blood flowing and so on, but nothing too extravagant for 8 weeks or so.
Yeah. Walking after hip replacement is fantastic exercise. People often ask, why have you not referred me for physio after my hip replacement? And oftentimes we don't do, and that's because normal everyday activity, and to sit down you need to flex the hip to 90 degrees. To stand up you have to maximally extend the hip. So you don't really need to do range of movement exercises with the hip. We're telling you not to by if we're having hip precautions, they don't flex the hip too much. And then the muscles around the hip, the balancing muscles around the hip have to work so hard just to walk. So when you walk, you're obviously standing on one leg, intermittently, one side to the other. So the muscles, because of the mechanics and the levers around the hip, the muscles have to work so hard just to balance the body weight on top of the hip that the force they have to create by doing that is far greater than lying on your side lifting your leg in the air. Right. So kind of those kind of exercises, whilst they're really helpful sometimes for coordination and those kind of things, and working on specific exercises, in general, they have to work a hell of a lot harder just to walk. Yeah. So I tend to advise patients, just take it easy, get out for a little bit of a walk every day, and gradually increase the distance that you're doing. And then we'll touch base at 6 weeks, and then we'll see if you need specific input. Or, you can just be let loose and just go for it. And if you contrast that to the knee, so in the knee, if you have a knee replacement, it's very easy. If the knee is painful, it's very easy to stand up with it slightly bent and to sit down with it quite straight. So you can avoid moving the knee very easily.
Right. Okay.
You can't avoid moving the hip very easily. So that's why people often, need quite a lot of input with physio after knee replacement, because it hurts to bend it, and you really do need to bend it in that first 6 weeks. Otherwise, it'll get really stiff. So that's the kind of the difference between that kind of post-op period. And that's why people say that it was really quite easy to get over my hip replacement, but when I had a knee, crikey, that was really hard work.
Right. Interesting. Well, I think that's a nice point to kind of draw this to a bit of a close. I think by no means have we covered all the possible risks and complications, but we've certainly taken a somewhat meandering path around the main ones. I realize now as I'm talking that we didn't talk about constipation, which I know is a frequently encountered and asked about one, but perhaps we'll have to do an interview with someone on constipation and how to reduce that.
I suppose one of the parting comments that I'd say really is that I think it's really important as a patient, if you're seeing somebody and talking about these things and talking through the risks, if you're aware of something or there's something that really worries you, maybe a neighbour's had a problem, or someone that's had an issue, or you just read about something that you're worried about, and the doctor doesn't talk about it, ask them about it. It's really important that that consenting is all about trying, as a doctor, you try and tell patients everything you think they need to know, but sometimes you don't, and there's something that's niggling them that they're really worried about, that's important to them. It's hard to get to that. I always ask is there anything else you're worried about? But sometimes patients won't, and they'll hold back. But please, I just ask people, please ask about everything you're worried about.
I think that's a really great point to end on, and it kind of again highlights that this is very much a personal conversation between each person and their surgeon, and how these possible risks and complications relate to the things that make your life meaningful and the things that you do.
Yeah, absolutely. And obviously you can, we've been talking for sort of over an hour on these problems, and clearly, in a consultation, where you might have half an hour consultation where you've got to talk, get to the diagnosis, examine the patient, talk through the options, and then talk about hip replacement. There is not time to go into the level of detail that we've talked about today. So that's when I think resources like this, that people can dip back into and look at later or beforehand, are really valuable.
Yeah. Well, and I really do hope that you out there who's watching this right now have found this helpful. If there's anything you feel that we've missed, and we certainly haven't covered everything, do let us know with a comment. As ever, feel free to send in suggestions for other topics to cover, and just let us know what you think, and hit the subscribe button. There'll be more videos like this coming, and don't forget to update your progress in the Joint School app. And thank you very much, Professor Board, and thank you everyone for watching.
Cheers, guys.
Yeah, fantastic. All right, stay safe everyone out there. We'll see you next week. Bye-bye now.